Impact of stroke on balance and postural control. Exploring how stroke affects balance and posture in patients. Many stroke patients experience sensorimotor deficits that impair balance. Balance impairment significantly impacts independence in activities of daily living, ADL, and gait, and is a major risk factor for falls. During quiet stance, patients exhibit both postural abnormalities, often standing asymmetrically with the center of pressure, COP, shifted toward the nonparetic leg, and postural instability, characterized by greater body sway compared to healthy individuals. Neither postural asymmetry nor instability is consistently associated with the side of the lesion. However, patients with right hemispheric lesions tend to demonstrate greater instability and reduced ability to voluntarily shift body weight onto the nonparetic leg compared to those with left-sided lesions. Due to their postural asymmetry, stroke patients unsurprisingly struggle to maintain weight bearing on the paretic leg, which directly affects gait performance. This asymmetry influences walking patterns during both linear and curved trajectories and is linked to weakness in the paretic leg muscles. However, muscle weakness alone does not fully explain the asymmetry. Altered vertical perception, often experienced as a contralesional tilt, may also contribute by causing patients to lean toward the nonparetic side. Additionally, studies involving galvanic vestibular stimulation suggest that disrupted corticobulbar projections to brainstem pathways involved in vestibular balance control may further contribute to postural abnormalities. Regarding postural instability, increased body sway appears to stem from sensorimotor and cognitive impairments rather than spasticity alone. For instance, patients with amyotrophic lateral sclerosis or spastic paraparesis do not exhibit increased sway during quiet stance despite lower limb spasticity. In stroke, instability may result from impaired sensory integration and abnormal verticality perception during upright stance. However, the relationship between increased sway and weight-bearing asymmetry is complex, as no direct correlation has been found between sway magnitude and medial lateral COP position. The heightened sway may also be attributed to greater reliance on visual input for controlling medial lateral sway velocity due to reduced sensory feedback from the paretic limb. Consistent with this, postural sway is more pronounced when loading the paretic leg compared to the nonparetic leg. During platform-induced postural perturbations, stroke patients exhibit delayed onset and reduced amplitude of postural responses in the paretic leg. Furthermore, while the nonparetic leg shows normal muscle activation timing, distal before proximal, the paretic leg demonstrates coactivation of proximal and distal muscles. This asymmetric muscle activation may contribute to an increased risk of falls. Early postural responses to stretch, mediated by hyperexcitable monosynaptic reflexes, are enhanced, whereas late responses, dependent on spindle group 2 afferent fibers, are diminished. This suggests distinct descending neural control mechanisms for early and late postural responses. Stroke patients also display deficits in posturokinetic coordination. When performing arm flexion while standing, anticipatory postural adjustments, APAs, are bilaterally delayed. Additionally, tasks such as rising on tiptoes are impaired. Healthy individuals activate the tibialis anterior before the soleus to shift the body forward and prevent backward imbalance. In contrast, stroke patients exhibit delayed activation of the paretic tibialis anterior, leaving insufficient time for forward weight shift and increasing the risk of instability during the movement.